Hello people. So today I want to talk about pneumonia. So pneumonia is actually, in simple terms, if we are talking, an infection of the pulmonary parenchyma. So this pink tissue, the pulmonary parenchyma, is infected in pneumonia. There are many classifications of pneumonia, but the most significant one is the classification on community-acquired, hospital-acquired, and ventilator-acquired pneumonia. So we will now see why is this classification so important. So first of all, we have the community-acquired pneumonia, the hospital-acquired pneumonia, and the ventilator-acquired pneumonia. So obviously, the first one, in its name, we have this community. Community-acquired pneumonias are, as the name states, acquired in the community. So the patient had no contact with the healthcare system, and the patient was not hospitalized and was not put on a ventilator. He was normally living his life, and he somehow got pneumonia in the community and presented into your health office. Then we have the hospital-acquired pneumonia. The hospital-acquired pneumonia, as the name states, has developed in a clinical setting in the hospital. Patients who have been hospitalized for for 48 hours or more, or 2 days, and if they then develop symptoms, this is called hospital-acquired pneumonia. So 48 hours need to pass in the hospital, so we can call it hospital-acquired pneumonia. If 48 hours don't pass, then it is actually a community-acquired pneumonia. So 48 hours or more in the hospital, in a hospitalized patient, if he has after this time shown symptoms, it is a hospital-acquired pneumonia. A ventilator-acquired pneumonia, acquired pneumonia develops in patients that have been put on a mechanical ventilatory device. So the important and significant element of this classification is that community-acquired pneumonias, so these ones, actually happen most of the time with pathogens that are not resistant to antibiotics. So these are simple pneumonias most of the time. And many of these pneumonias, so almost more than 80%, are treated outside of the hospital. Less than 20% are being treated, need to be put into a hospital and treated in the hospital setting. So pathogens have actually no significant resistance to antibiotics when it comes to the community-acquired ones. Most of them are actually caused by pathogens like Streptococcus pneumoniae or viruses. 50% of these pneumonias we don't even know what is the cause. So in 50% we don't know the cause, but they are actually easy to treat, and most of these patients recover adequately. The problem here is the hospital-acquired pneumonia. So here in these pneumonias we have a problem that we have multi-drug resistant pathogens. So these pathogens are resistant to 3 or more drugs. And then we have a problem how to treat this. We need to do sputum analysis, we need to do a lavage, we need to do an extensive workup to define what is the pathogen and what antibiotics will work on it. So this is a more serious term than the community acquired. And that is the important differences this classification is stressing. The ventilatory acquired pneumonia only, it can be caused by pathogens that are not resistant to antibiotics, but it can also be caused by hospital pathogens that are multi-drug resistant. But it is happening by patients that have been put on a ventilator machine, and this mechanical ventilation predisposes them extremely to developing pneumonia. There is one more term, and this term complicates this classification a little bit. So this term is actually healthcare acquired pneumonia. So I put it in between those two because it is not a typical community acquired pneumonia, but it is also not a typical hospital acquired pneumonia. It is in between these two. This term is in between these two elements. Why is this term being coined now? We start seeing patients coming out of the community, but they are presenting with more and more with multi-drug resistant pathogens. So the significance of this is that people who had some contact with the healthcare system, they have a bigger chance of getting an infection in the community, but with multi-drug resistant pathogens. These people are mostly our elderly population, people who have chronic problems, like, for example, who do chronic dialysis, people who need to get some therapy, infusion therapy at their home, people that are living in nursing homes, or people that have been hospitalized for more than 2 days in the last 3 months. So some people that had contact with the healthcare system have a possibility to acquire a community acquired pneumonia, but with multi-resistant pathogens. So this term is put into the middle of these two. And this is very significant because when a patient presents to you, you need to analyze this and see is this a community acquired pneumonia that is most likely to have a favorable outcome, or a hospital acquired pneumonia that can be caused by dangerous multi-drug resistant pathogens. So the next points I want to talk about are actually those classical elements we always talk about, and that is etiology, pathophysiology of these pneumonias, how a pneumonia develops and what are the causes. So most of the time the cause of pneumonia, so if we talk about etiology, most of the time the etiology is caused by bacteria and viruses. So when it comes to bacterial pathogens and viruses, also fungi and parasites can cause pneumonias, but bacteria and viruses are the most common ones. So when it comes to bacteria, we have, for example, gram-positive bacteria like Streptococcus pneumoniae, which is a very common, especially in community-acquired pneumonias. This bacteria is very common. Also, Staph aureus is a possibility, and the problem with Staph aureus, many of these Staph aureus bacteria have a multi-drug resistant potential, especially MRSA in the clinical setting, or methicillin resistant Staph aureus. These bacteria would cause a typical pneumonia with typical pneumonia signs, but there are also some other bacteria. For example, that would cause a atypical pneumonia with some atypical signs, harder to diagnose, like mycoplasma pneumonia, like chlamydia pneumonia, legionella, and so on. There are also gram-negative bacteria that can cause pneumonia, like Klebsiella pneumonia, like Haemophilus influenza, and like Pseudomonas aeruginosa, and this one is also prevalent. These are Klebsiella and Pseudomonas can be found in the hospital setting. It is also speculated that a very large amount of cases of pneumonia is caused by viruses. Also, some specific pneumonias can be caused by special bacteria like tuberculosis, TBC. When it comes, so the etiology, if we simplify it really, is bacteria and viruses, and bacteria can be some like Streptococcus pneumonia, which is the most common one, but also these other bacteria that have potential to cause atypical clinical pictures and that have potential to cause pneumonias that are multi-drug resistant. When it comes to the pathophysiology of pneumonia, there are three main ways we develop pneumonia. The first one is the most important one and the most significant one, and that is aspiration. Aspiration and inhalation. So inhaled pathogens and aspiration is the most common way. So the most common way we develop a pneumonia. We aspirate fluids, or we inhale pathogens in droplets from the air, and they overcome all our barriers and come to the tissue and overpower our tissue macrophages and alveolar macrophages, and the infection or pneumonia develops. The second one is rare. So there is a possibility for a hematogenous spread, but this type is rare. So you need, for example, to have an endocarditis, an infection in the heart that will hematogenously spread and infect your lungs. The third possibility is the continuous spread. For example, you can have a wound that spreads the bacteria from the skin to the lungs, or you can have a pleura infection that then spreads to the lungs. But this one is the most common one, and it is always emphasized in any medical book. So the pathophysiology of the development of pneumonia, it has always been emphasized that our mechanical barriers or factors, our mechanical factors are actually critical for the defense of pathogens that cause pneumonia. These factors are this branching of the bronchial tree. So this branching is making it harder for bacteria and viruses and pathogens to get deeper in our respiratory system. Our mucociliary apparatus that is actually moving the opposite way, trapping bacteria in the mucus and moving them out of the system, is also one element. The local proteins that are being secreted, defensins, surfactant proteins, are antimicrobial agents that eliminate these microbes. And the last barrier are our alveolar macrophages. These cells can eliminate, devour bacteria and viruses and contain them. If this barrier is overpowered, the macrophages are dying. A lot of interleukin-1, tumor necrotic factor alpha, interleukin-8, and many of these interleukins and factors are being secreted, and then the clinical picture starts to develop. We start to develop fever, cough, shortness of breath, and so on, but also on the cellular level, neutrophils start invading the tissue, and the reaction, the acute inflammatory reaction starts to develop in a serious manner. And the symptoms, the host inflammatory response, rather than the proliferation of the microbes, is the one that is triggering the clinical symptoms of pneumonia. So if all these mechanical factors fail us, and these mechanical factors mostly will not fail in a young healthy adult, people that have structural changes in their respiratory system, like elderly people, normally because of aging, people who are smoking cigarettes, people who are living in air polluted places, have a higher possibility, of course, to develop pneumonias because of the destruction of these factors. Keeping these factors alive means keeping pneumonia away. Now, what is the typical clinical presentation of pneumonia? So, the clinical presentation, fever is one of the obvious ones. So fever. Then we also develop cough most of the times. This can be non-purulent, or it can be with sputum that is mucoid, purulent, or even blood tinged. So mucoid, or even with blood. Then also people can develop fatigue, and people can develop shortness of breath. Sometimes, if the pleura is involved, there can be a specific chest pain called pleuritic chest pain. So I would say that these clinical factors are the most common ones you would see in a patient that has an ongoing pneumonia. Obviously, this is a typical pattern. Sometimes pneumonias can present very atypically, and patients you need to watch out for are children and elderly, especially elderly patients. Elderly patients can have a not really that obvious pneumonia. So sometimes, for example, a simple case of this not obvious, so none of these symptoms can be present. Elderly patients sometimes come in with a pneumonia, and the only symptom can be, for example, a new onset or a worsening confusion. So And only on checkup and on evaluating this patient, you find out that everything is caused because the patient is decompensating because of this pneumonia. So this patient can decompensate very rapidly, and in elderly and in children, we need to be very, very careful. Healthy adults will most of the time, if they have no underlying conditions, most of the time, these patients will clear the pneumonia with a simple antibiotic. Then the diagnosis, so clinical. How is the diagnosis made? If we're talking about a setting where the doctor has not so many, he's working in a simple little hospital, the main elements are taking a good patient history and doing a good clinical examination. So these two are crucial to understanding what is the problem of the patient. On the clinical examination, on auscultating the lungs, you can hear on auscultation, you will probably hear crackles. Or a diminished lung sound, or even no lung sound. On percussion, you will hear a more dull or flat lung sound. So this, for example, you can compare it to a barrel. Normally, lung sounds as a barrel that is not filled with fluids. But when you develop pneumonia, you have exudate, so developing, and the lung sounds pathologically as a barrel that is filled with some fluids, and this sound is a little bit dull or flat. So in pathology, the infection of the lung develops. We have first the initial phase, then we have exudate, and then we have the red hepatization phase, and then gray hepatization phase, and then we have resolution. So in these phases, the lung is filled with exudate, with cells, and it will sound on percussion more dull than it should. These everyone can do, except these. Obviously, you can analyze the blood and see if there is leukocytosis, and for example, proteins like CRP, to see if there is acute inflammation. And with these elements, every hospital has the possibility to do an X-ray of the lung. So I would say that with all these three diagnostical tools, so the clinical examination, the blood work, and an X-ray, you can have a pretty good idea what is causing the patient trouble, or is it actually pneumonia. So if you are not sure, and if it cannot be distinguished with these parameters, then you need to send the patient to a higher institution that will do CT, that will do gram stains, analyze sputum, analyze a lavage, do serology, do a PCR, and so on and so on. But every hospital has the possibility to do this, and most community-acquired pneumonia don't need any more diagnostics. In healthy adults that develop a community-acquired pneumonia, this is enough, and then we can go on to the treatment of our patient. So the therapy, obviously, pneumonias were a very big problem for people when we didn't have antibiotics. Now they are still a very big problem because we have multi-drug resistant pathogens. In this community-acquired pneumonia, the pathogen is mostly susceptible to many antibiotics. For example, a simple case that you can treat yourself, that doesn't require hospitalization and hire specialized personnel and diagnostics, is, for example, a young man comes into your office and says, 3 weeks prior I had a common cold, and now I have some cough, fever, fatigue. I am coughing out some mucoid or purulent sputum, and you do this analysis and see that he has a limited pneumonia in his, for example, left lung. He has some crackles in the lower left lung. He has leukocytosis development. The CRP is not that, for example, the CRP is 50. An X-ray shows a small patch of consolidation. And if this patient is healthy, if he does not present with severe problems like a very high fever, if he has a relatively good saturation that is not falling below 95, if he does not have a raised or very low blood pressure, if he has no tachycardia or bradycardia, this patient can be treated in the outpatient setting, and you can be very secure that he will react to therapy probably very well. In these patients, you can a drug that is given and today that is given very often and that is proven to treat these patients very well is azithromycin. 500 milligrams, 1 tablet a day for 3 days. So this is a very good drug, and most of the time it clears these pneumonias. If you have something other than this, you have an elderly patient that has tachycardia, that is coughing up blood. If you hear a pneumonia that is on the both sides of the lung, if there is any, and I mean any doubt in you that you can treat this as an outpatient pneumonia, and if you think that the patient will decompensate, if it is a child or an elderly patient or someone who has severe risk factors like COPD, diabetes, stroke, or if you think that this is an atypical pneumonia, if the patient was exposed to some kind of bats, birds that carry significant pathogens, you need to refer this patient to a higher institution. So to a higher institution that will treat this patient with some advanced diagnostics and therapy. When it comes, only briefly, when it comes to hospital-acquired pneumonias and ventilator-acquired pneumonias, hospital-acquired pneumonias are most of the time caused by multi-drug resistant pathogens and also anaerobic pathogens. Anaerobic pathogens are mostly, when they are causing problems, they often develop together with other pathogens and often are found in abscesses and empyemas in the blood, in the lung. Ventilator-acquired pneumonias can be caused by both drug-resistant and not drug-resistant pathogens, but these patients are already very sick, and any other disease on their system makes their treatment significantly harder. So this is the basic overview of pneumonia, and obviously pneumonia, with this crisis with COVID and everything else, bacterial and viral pneumonias are here, and they are here to stay.